Dr. Kristin Dean is a licensed psychologist and a health service provider and is a board-certified specialist in clinical psychology. She is an associate professor in the Department of Family Medicine in the Graduate School of Medicine at the University of Tennessee and director of the Center of Excellence for Children in State Custody. Dr. Dean is also an adjunct researcher for RAND Corporation and has been a member of SAMHSA-funded Trauma Services Adaptation Center for Hope, Resilience, and Wellness in Schools and Communities since 2003. So without further ado, I'm pleased and honored to give you Dr. Kristin Dean. Oops, hold on, Chris.
Can you hear me?
Yep, there we go.
All right. Good afternoon, everybody. Thank you for joining us today. We appreciate your time and your interest in this topic. And thanks to Dr. Berkeley for helping us with the tech side of things. We, if you've been to our learning cafes before, you know we tend to hold these most months, and we like to do them in person, but you know, given the conditions right now, we're sort of holding these virtually, so we're kind of learning as we go, so we appreciate your patience. A couple of other housekeeping things besides what Dr. Berkeley covered. I just want to remind everybody that we will be sending you a link to a survey at the end of this, and we really would love your feedback. Give us your thoughts on how this went and your ideas for future topics. We really use those to kind of help plan our curriculum. So let us know the things that you would like to hear more about, and then we will give you a certificate. We'll give you a certificate that says that you were here and present for the session. So we'll do that at the end. And also, before I start, I wanted to just take a moment to acknowledge the date today. So June 19th or Juneteenth. We've been hearing about this in the media, but so I just want to pause and recognize it, and certainly remind us all that we do have cause to celebrate the abolition of slavery, and we want to take time to celebrate that. And we also want to take time to acknowledge that we still have a lot of work to do in ensuring that all of our citizens have true equality. So keep that in mind today, beyond just this presentation. So, all right, well, let's talk about attachment and healthy attachment, and how can we build healthy attachment. All right, this is sort of strange for me, I will just tell you, because I can't see you. So I'm sort of talking to my screen right now. So I'm relying on Dr. Berkeley to fill me in with any questions or comments or tech issues that I need to be aware of. Okay. Now, how do I advance? There we go. So I have a lot of material to cover. I will tell you that I have a lot of slides. So I might go through some of them rather quickly, but we do have copies if you're interested in getting a copy of the slides. Karen, our administrative specialist, will make sure that you get those. So just let her know if you're interested in that, in case we go over things quickly. But I would like to start by defining attachments. We're all on the same page. What are we talking about when we talk about attachment? How does that present diagnostically and clinically? What is it related to? What do we know about the cause of poor attachment and the correlates? What are the outcomes that we know about? And then what are finally the best practice recommendations for strengthening healthy attachment? So we know that healthy attachment really requires a nurturing environment. That is the key, right? We need an environment that is healthy for the child, that nurtures their growth, that provides basic needs like hygiene and shelter, rest, appropriate levels of stimulation, routines and structure, having things be predictable and safe. It also requires a nurturing caregiver, right? And the attachment theorist Winnicott famously said there's no such thing as a baby, and some of you might have heard this before, that by definition, babies can't exist without a caregiver, right? A caregiver is essential for a baby's survival. So they don't exist on their own. They only exist in relationship to their caregiver. And so those relationships are absolutely necessary for survival. They won't make it without it. So caregivers really are key to ensuring that the child understands sort of how this works. Like, what behavior do I need to do to survive, and how can I feel secure in that behavior? Most attachments, healthy attachments anyway, are mutually rewarding and reciprocal, right? There's enjoyment within each party, the infant and the caregiver, right? We like to engage in attachment behaviors with infants and with babies. And it's something that we really do naturally. We don't always even think about it. So if we had a baby show up on our screen, like if I brought a baby in here, or if one of you had a baby, I was in a training yesterday, actually online on Zoom, and one of the women there had her baby that she was holding and feeding. And as soon as the baby showed up on the screen, what do you think we all did? Like, everybody stopped and just went, "Oh, the baby," right? And we all responded, and we all had this change in our affect and this change in our speech. It just happens naturally. We don't even think about it. But it's something that is so important that happens. And it's nice that for most of us, it just comes naturally. And you think it's just something we do. That's what you do when babies come in. We don't even really know where that comes from. But there's a lot going on in those interactions, right? They're not just fun and cute, those babies, but the way we respond to them and the way we interact with babies really helps that baby's brain, and it helps them learn how to soothe, how to structure, right? That we regulate infants' emotions through that soothing and structuring that we do with them, through the stimulation we do with them when we play with them, by encouraging them, right? We're really helping to regulate those infant states. And that emotion regulation leads to the development of self-control and behavioral regulation. It's so important. That security and sense of importance and being important to somebody else really helps build trust and really helps infants develop their sense of self. Caregivers typically, typically really want to please their caregivers, right? They like their caregivers, they want their attention, they want to please them, they want to do things that the caregiver wants. And when the caregiver reinforces their behavior, that's how they establish patterns for being and doing, right? This is kind of how we do it. You cry, I respond. You smile, I respond, right? And we have this interplay, this interaction, and that's how the child learns to regulate. And it's how they learn expectations and consequences as they go through life. So it starts early. And like I said, there's a lot happening there and a lot of happening in the baby's brains during those interactions. So I want to show you a clip from the still face experiment. And some of you might have seen this before, but it really highlights the importance of that interaction to young children, that they want and need that interaction. And when they don't get it, they will let you know. So here's a clip. Hopefully the sound will work.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In this still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay, so there we see it in sort of real time, how the baby responds when mom disengages, right? And thinking about how important that interaction is to the baby and how much she wants that interaction. And I find, I don't know if you found that's hard to watch for a minute, even though it only lasts very briefly. It's hard to see that baby in distress when she's not getting what she needs from her caregiver, right? All right, so let's define attachment a little more clearly. So this is sort of a diagram, if you will, of attachment behaviors in a healthy attachment cycle. And so this is kind of what we just saw in part. When a baby expresses a need, a child has a need, right? Whatever that need is, maybe it's attention, maybe it's hunger, maybe they're tired, maybe they need a diaper change, right? But they express some type of emotion, or they give us some type of behavior, and then the caregiver meets that need, right? So the baby cries, the caregiver picks the child up, soothes them, talks to them, helps them, changes the diaper, feeds, whatever it is. When that happens over and over again, like it does with infants and young children, those of you who are parents can speak to this, how often you have this attachment cycle in one day, right? The child learns that relationships are predictable. So I know that when I have a need and I express that need, I know that this caregiver is going to respond to me. And when that happens, it helps me regulate, right? It helps the child lower their arousal. It helps me know that I can go through this normal stress response and be okay, right? Like I know that if I get hungry at some other time, I don't have to be frightened because I know my caregiver is going to come and take care of me and meet that need. And when you go through this over and over and over again, that really gets reinforced, and the child learns to trust, and they learn that relationships are safe, they're trustworthy. It helps the child have a positive internal working model of themselves and of others, right? That I'm important, what I do matters. I know that when I cry, this person comes. And I know that when I'm happy, this person is happy too, and they share that with me. And they anticipate that future responsiveness. So we can see how that, how those attachment behaviors work in a caregiving system repeatedly, right, over and over again. So there are a number of ways to define attachment, and sort of all organizations have their own different way. Essentially, it's behaviors that we see in young children in which they seek comfort, support, or protection. So that's when the child has had these healthy attachment behaviors with a caregiver over and over again since infancy, and the child starts to develop this attachment to this person, and that person becomes a primary caregiver. Now, a child can have more than one, doesn't just have to be one, but it's usually in our culture, in the United States, most of our kids have 1 to 2 primary caregivers, but in other cultures, they might have multiple, especially families that live together with multiple generations. But it's the same kind of behavior. The child will go to certain people for comfort, support, or protection. And this starts to emerge just around the end of the first year, when we start to see they are less comfortable with strangers. So for example, a 6-month-old baby will just be happy to be held, right? And you can sort of pass the baby around among family or friends, and they're happy as long as someone's holding them or feeding them or something. But as the child gets older, they start to discriminate between caregivers, and they will start to become less comfortable with that, and they will start to not want to be separated from that primary caregiver. You see this in daycares, right? When you drop your child off as a baby, again, they're sort of happy to go to whoever. And then it's like, as they get older, even though they've been going there for a while, they might start to get anxiety when the caregiver leaves, when the primary caregiver leaves, right? And they have that separation anxiety. Very normal, very healthy. It just means that cognitively they're more aware and they're starting to discriminate between caregivers. And then once they achieve mobility, once they're up and walking, then we see even more attachment behaviors, because as they get bigger, they have more freedom to explore, right? And they can move and they can go around and explore their environment, and we expect that. But we also see that they have a need to check back in, that primary caregiver really serves as their secure base, if you will. That's like home plate, okay? I'm gonna come back to home plate. I wanna go check things out, but I'm gonna check back with my caregiver. We also call this rapprochement, right? I'm gonna go out, but I'm gonna come back and check back in. In that healthy attachment, we want a caregiver who's gonna encourage that exploration, but who is also gonna watch out for them and make sure they're okay, and be there when the child needs to come back and refuel. The circle of security model really provides a nice example of this kind of rapprochement and attachment behavior. So the secure base, you see the hands there on the left side of the screen. That's the secure base, that's the primary caregiver. And so if you start up top, the child says, I need you to support my exploration, right? I need you to encourage me to explore. We want our kids to get out and explore the world. But I also need you to watch over me, to help me, make sure I don't do anything dangerous. Kids are at a great threat to themselves when they're around this age, when they first get mobility and they don't have a good sense of safety, right? So we need to protect them, watch over them, help them, but also enjoy with me, delight in me, be excited about the things I'm excited about too, right? And then when I'm getting tired, I need you to welcome my coming back to you, right? When I need to come back and refuel, or if I get frightened or whatever it might be, I need you to welcome me back to you, and I need you to protect me, comfort me, delight in me, and help organize my feelings, right? Something also that we tend to do instinctively with infants and young children is mirror their feelings, right? And if a child comes to us and they're distressed, we sort of match that face, we mirror that face with them, and we label it. And we say, oh, are you frightened? Did that frighten you? Did that dog scare you or something? It's okay. The dog's over there. You're okay. I've got you, right? We're going to sort of help them organize their feelings and regulate their feelings. So in order to study attachment, Mary Ainsworth came up with a very clever way to look at how young children respond to their caregiver in different situations, okay? So this is an old drawing that I found on the internet, which is sort of fun, this old sketch of Mary Ainsworth sitting there with a parent, with the child. And the scenarios really are looking at the caregiver and child together, looking at the child when they're with a stranger, in this case, a researcher, somebody in the lab who came in to help with the study. And then how is the child alone? Those are the scenarios. And then what we're looking at is what is the child's behavior when they're with the caregiver, when a stranger comes in, when the caregiver leaves, and then when the caregiver returns? How does that child respond to their caregiver? What does that attachment look like in young kids? And here she is. This is Mary Ainsworth sitting down with a young child. What they found was that 3 types of attachment emerged: secure, insecure, and disorganized. So the securely attached kids are the ones that really approach their caregiver unambiguously. So they may or may not have been distressed when the caregiver leaves, kind of depending on their age. Some might have been, some might not have been. But what's important is that when the caregiver returned, they connected with the caregiver again. So if the child was distressed, they went to the caregiver, they sought that comfort and protection, and they responded when the caregiver soothed them. If they were not distressed when the caregiver left, maybe they did okay when the caregiver was gone, and when the caregiver comes back, maybe they're excited to show the caregiver what they were playing with, right? Or they're happy to see their caregiver, they go to them, okay? So it's that unambiguous, this is my person, I'm gonna seek you for support. The insecurely attached kids had really mixed reactions with the caregiver. Some of them might have been angry with the caregiver, so the caregiver comes back and they don't go to them because they're upset, right? They don't seek that support. Or they might go to them but not be easily soothed. So they approach them, they sort of know that they should be soothed by them, but they don't respond well to being soothed because they're so upset. So there's that insecure, I don't know what to do with this. And then the disorganized kids are really those that didn't have a clear pattern in terms of how they responded. It was sort of this real ambiguous, I want to approach you, but I don't trust that it's safe. And their behavior just sort of seemed disorganized, which is why they labeled it that way, right? That the kids didn't show a good pattern with their caregiver. So those are kind of the 3 primary types of attachment that emerged. And this study
Chris, one moment, your microphone seemed to have gotten muted. There you go.
Okay, there we go. Sorry. So I was saying that it's been replicated in different cultural groups, even with multiple caregivers. This has been a really clear, kind of predictable pattern among kids. But we don't really have good data on trajectory. So what does this mean? So if kids have an insecure attachment, what does that mean later in life? And there's not a set pattern. They do theorize that there may be more problems with mental health issues in adulthood for the kids that had a disorganized attachment, where there wasn't a clear pattern and the behavior was just disorganized. But there's a lot we don't know about what attachment looks like later in life. Okay. So what are the risk factors for a poor attachment? Which kids are most likely to develop a poor or an insecure attachment? Well, things that, probably wouldn't surprise you in terms of what's gonna, stressors for caregivers. So things like poverty, lack of access to safety and services. If you're living in an unsafe environment, you don't have a lot of support, then the family is going to be stressed. Certainly in situations where there's maltreatment. Institutional care, meaning kids who from infancy are placed in institutions where there isn't a lot of caregiver attention or affection. We hear about these oftentimes in other countries. Having marital discord or partner violence certainly is a risk factor. And then caregiver issues, any issue that's really going to interfere with the caregiver's ability to be appropriately attuned and attentive to their child. So having depression, for example, a severe mental illness, having an active addiction, having unresolved loss or trauma among the caregiver, having a caregiver that didn't have good caregiving themselves, right? Where they didn't have a caregiver that was appropriately attached to them and that maybe they don't know how to do that as a result of that. So a lot of factors that can contribute. There's no one thing, except as we talk about some of our diagnoses, neglect and really severe neglect can result in severe attachment problems. So if we go back to our cycle of attachment behaviors, we can see how if a child is expressing an emotion or a behavior and that need is not being met, so the caregiver is either unresponsive or abusive potentially, or is inconsistent, that also can send a real confusing message. Sometimes they come, sometimes they don't. Sometimes they soothe me, sometimes they punish me, right? That teaches a child that relationships are unresponsive or potentially dangerous, which means the child feels out of control, right? Their emotions and their feelings don't get regulated by that caregiver. And so they are in a state of chronic stress and emotional discontrol. And the lesson learned then is relationships are not safe. And I have to be hypervigilant to whatever's coming. So I either need to be like super aware and watching at all times, or I need to just shut down because that's easier than not being responded to. And then you can imagine what the internal working model is of themselves, right? I don't matter. Either nobody pays attention to me when I have a need, or maybe they punish me when I have a need. And so I'm bad, or what I do doesn't matter. And that the world is not a safe place and I can't trust people. All right, so we tried to quantify attachment into a diagnosis, into a disorder. You know, we have these, we have this research from Mary Ainsworth about the different types of attachment disorders, but we don't really diagnose them as an attachment. We don't have like an insecure attachment disorder diagnosis. But they did try in the DSM-3 to come up with an attachment disorder diagnosis. So they came up with a reactive attachment disorder in the DSM-3, which was published in 1980. And it included failure to thrive. So the child had to show evidence of failure to thrive, like malnutrition, that sort of thing. And it had to be present by 8 months. Okay. So I don't know about you, but I have a hard time getting a good history in children before age 5. I can't imagine trying to get a history of what this child was doing at 8 months old in terms of attachment behaviors, but that was the criteria back then. They modified it with the DSM-3R, which was published in 87. And they removed the failure to thrive, so there doesn't necessarily have to be evidence of that. And they changed the onset to within the first 5 years. So in order to diagnose this attachment problem, we have to see these attachment behaviors sometime before age 5. Okay, in the DSM-4 TR, that was published in 2000, and this was the first time that they split the reactive attachment disorder diagnosis into 2 different subtypes, and they called it inhibited and disinhibited. And they also added that this behavior, this inhibited behavior or this disinhibited behavior, is caused by grossly pathogenic care. So that was our diagnosis for a long time with the DSM-4, and there were some problems with it, obviously. There wasn't any evidence really. Like, we didn't start studying that particular diagnosis until 1998, which is like almost 20 years after it was first introduced. So I think we kind of made this attempt to have something, but we didn't really study it like maybe we should have before we kind of put it out there. So we didn't have good evidence, you know, for the criteria for that disorder, and there were a lot of comorbidities. So kids who seemed to have these attachment problems also had lots of other things like ADHD and depression or oppositional behavior. Okay. But it's really like it's our only attachment diagnosis that exists. So if you feel like a child has an attachment issue, I think what was happening is people were giving that diagnosis because it was really all they had, right? So on the one hand, I think it's important that we recognize attachment issues in children and that we pay attention to that and intervene on that level to try and build healthy attachments. But at the same time, we don't want to use a diagnosis that's maybe too narrowly defined based on what a child is presenting with. So we ended up with this sort of weird situation where we probably weren't considering attachment enough in terms of our clinical conceptualization, but we were overusing the RAD diagnosis, the reactive attachment diagnosis. At the same time, in the 90s, this diagnosis really became sensationalized in the media. And for those of you that are old enough to remember, there were like, you know, these like news program shows like 2020 and these different programs talking about these radical treatments for reactive attachment disorder. And so it got a lot of media attention for a while, which is always dangerous. So that was happening. At first, they did not have any proposed changes to make in the DSM-5 when they were thinking about reactive attachment, but they ultimately did make a couple of important changes. So they changed the term grossly pathogenic care to inadequate caregiving environments, which still essentially means that these kids have a hard time attaching because of their caregiving environments, right? The other thing they did is they really separated those two clinical patterns into two different diagnoses. So it went from reactive attachment disorder with, you know, inhibition or disinhibition to reactive attachment disorder and disinhibited social engagement disorder. Two different disorders, but they both are thought to come from inadequate caregiving environments. So I want to go through the criteria really quickly just to highlight what is required to diagnose a child with reactive attachment, because it is still pretty narrowly defined and we still think of this disorder as being pretty rare. So we think most kids, even if they have an insecure attachment, they have some type of attachment, right? That is not necessarily a reactive attachment disorder. So the first criteria, consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers, which is manifested by both of these two things. They rarely or minimally seek comfort, and they rarely or minimally respond to comfort. So they're not seeking out caregivers for that protection and support. And when a caregiver tries to give it to them, they don't respond to it, okay? Minimal response. So that's the first criteria. The second one is they have to have a persistent social and emotional disturbance that is one of these three things, or two of these three things. Minimal social and emotional responsiveness to others, limited positive affect, and episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with caregivers. Okay, so two of those three have to be present. The third criteria is that we think these behaviors are the result of insufficient care, and then they give examples of what insufficient care means. So social neglect or deprivation, meaning they don't have their basic emotional or physical needs met. Repeated changes in primary caregivers that limit opportunities to form stable attachments. They give the example of frequent changes in foster care. And this one I kind of have a hard time with, because I think it has led to people assuming that because a child has had multiple placement changes that they have a reactive attachment disorder. We find most kids in foster care do not have a reactive attachment disorder. Some do, but even kids who change placements, if they've had an opportunity to build a positive relationship with a caregiver, even if that caregiver leaves or things change, that still can establish this belief in children that some people are good. I can form attachments with some people. So just keep that in mind. And then the third criteria is rearing in unusual settings like an institution that doesn't have good caregiver to child ratios. Okay, so one of those has to be present. There has to be some evidence that they really have had some type of insufficient care. Okay. You cannot diagnose reactive attachment disorder and an autism spectrum disorder. Okay, if a child meets criteria for autism, you would not diagnose reactive attachment because by definition, children with autism have difficulties with social interactions and making those connections. We have to have evidence that this is present before age 5. Okay, so that's still there. And a child has to have a developmental age of at least 9 months. Okay, there are some specifiers. You can specify if it's persistent, if you've seen symptoms for more than a year, or as severe if they have every single symptom at high levels. Okay. So the disinhibited social engagement disorder is the new diagnosis now that is its own. So you wouldn't diagnose a child with both of these, probably. So the disinhibited disorder is really about a child who actively approaches and interacts with unfamiliar adults and displays 2 of the following: a reduced or absent reticence in approaching or interacting with unfamiliar adults, an overfamiliarity with them, so verbally or physically, just showing no boundaries, right? Telling them everything, climbing up on their lap, that sort of thing. A diminished or absent checking back with an adult caregiver after venturing away. So that rapprochement that we talked about, the circle of security, that they don't check back, right? They don't feel that need to check in and they don't worry about safety maybe. And then a willingness to go off with an unfamiliar adult. Okay, these behaviors are not limited to impulsivity. Okay, so this is not, you know, your impulsive ADHD kid who is just very talkative and friendly, right? Those kids will still show attachment behaviors with a caregiver and will check back and that sort of thing. So don't confuse it with just impulsivity. It's really the social disinhibition. They have to have the same criteria of insufficient care as reactive attachment. And the assumption is that that insufficient care is what caused this disinhibition. And same thing with developmental age and the specifiers.
Dr. Dean,
Okay.
a question real quick.
Yeah.
About reactive attachment disorder. There's a question about age requirements, and if this happens in infancy, can the child build on relationships as a teen later if they hadn't had the attachment as an infant?
Okay, great question. And we're going to talk about some of the research with that. The thought is yes. The thought is even if they meet criteria for that at some point in infancy, that if they can get a caregiver who is securely attached themselves and have an adequate caregiving environment, that they can form an attachment. So reactive attachment disorder does not mean a child is incapable of attaching to people. Okay, it might be harder, it might be trickier, but there's evidence to show that once they have a good caregiving system, that they will no longer meet that criteria. Great question. Okay, so the next few slides are just some of the research supporting why the folks who developed the DSM-5 chose to keep the 2 diagnoses separate. So I'll just go through them very quickly. The Tizard London Nursery Study was a pretty famous study looking at an institution where kids had really low caregiver ratios, and the caregivers were told not to attach to the children. And she found kind of this pattern of, you know, a third of kids seemed to be withdrawn, a third of kids seemed to be disinhibited, and a third of kids did show some selective attachment. There's a picture of Dr. Tizard. She's a psychologist in London. And interestingly, when the DSM kept reactive attachment disorder as one disorder with 2 subtypes, the ICD-10 had already split them. So the DSM was sort of slow to follow the ICD-10. The big thing, a couple big things, differences between the 2 disorders. Reactive attachment disorder kids, their kind of primary comorbidity is depression, right? So think of these kids as withdrawn, sad kids, whereas the disinhibited kids are the impulsive social kids with unfamiliar adults. The reactive attachment disorder are sort of depressed and not interacting well with their primary caregivers. Other things to consider, neglect is the key. especially with reactive attachment disorder. There are no reports of reactive attachment disorder without neglect, even in cases of abuse. So children can experience physical abuse or sexual abuse, but it's neglect is really the key to that reactive attachment. With the disinhibited kids, we don't know as much about them, and I think because this is a new diagnosis, we still have a lot to learn. But these kids have a strong correlation with kids with ADHD, and they look a lot like kids with Williams syndrome. So Williams syndrome is a genetic disorder that has a number of characteristics, but one of them is that they have this really outgoing personality that's really distinct from most typical kids. And so they're wondering if there's some kind of gene or something that both of these kids have that explains this kind of outgoing social disinhibition. Beyond early childhood, so kind of coming back to one of your questions, we see older kids and teenagers diagnosed with reactive attachment disorder, and it's really not appropriate. I mean, a child who met that criteria in infancy, certainly that's an important part of history, but it's really not meant to be carried forward forever, right? Like it might change into something else, like they might develop depression or a mood disorder or something like that, and they still might have some social difficulties, but the research around reactive attachment really is all done in infancy and early childhood. We think the cause is caregiving environment, and I've said that, so that this is just more research about that, and you can look at the slides if you want. In terms of child factors, again, most kids who are maltreated do not develop an attachment disorder. This is very rare. They might have an insecure attachment or disorganized attachment, but not necessarily reactive attachment. There have been studies trying to figure out if there's something about the child that makes them more vulnerable. So you put kind of a vulnerable child in a situation where they're deprived, and are they more likely to develop it? One study hypothesized that maybe there was a sensitivity period, like in the first 6 months, or the longer the deprivation, the more likely they were to develop. Course and outcome, these have been variable too. In general, they feel like the disinhibited kids are more likely to still show that pattern of disinhibition into adolescence. Less so, they say, with caregivers, but with peers, that can kind of persist. The reactive attachment can also be fairly stable if they don't have a good caregiving system. So if they've been institutionalized up to 54 months, which is 4.5 years, right, then they might still show symptoms. But most kids, if they are placed in a good caregiving system, those symptoms should abate. All the literature says that the best intervention is getting with a family, getting with caregivers that are securely attached. So there was a study looking at kids in foster care and getting placed with a foster parent. And they said most youth can form secure attachments compared to kids who were not maltreated if the foster parent is securely attached. But they said if the foster parent is insecurely attached, so they have their own kind of attachment issues and don't feel secure themselves, that might lead to more kind of a disorganized attachment with the child. With disinhibition, again, the results are really mixed, and I think we need a lot more research. So I don't want to spend a ton of time on the topic of theories. We kind of have gone over appropriate attachment theory. But I do want to just make you aware that there are other theories out there around attachment that are kind of less healthy, where the focus is on the child and something being wrong with the child, and the child really being pathological in some way. And I think this is developed in part because some parents are frustrated with kids who have poor attachment, and they're sort of looking for answers and end up being told that it really has nothing to do with them as caregivers, but this is just a child who has been maltreated, and as a result of their maltreatment, they've developed this rage that prevents them from attaching. And there's sort of this model that these kids, have no ability to attach, or that they don't have a conscience, or that they become antisocial. And there's no evidence for that. So if you hear families talking about that, and we hear it from time to time where parents are told different things, or they look things up on the internet and find different things. And we just want to make sure that they understand that really that theory doesn't have any research support. This is a checklist that I found online from an agency that does kind of controversial treatment with reactive attachment, and it's kind of up there, and families are told if your kid has any of these symptoms, they could have an attachment disorder. But if you read through them, there are things that lots of kids have. So again, just kind of being cautious with parents. If the controversial treatments that have been out there, I hear less about these now, fortunately, but things like rebirthing or regression, where you're trying to bring them back to infancy and then reparent them. Holding therapy, this was like taken from a manual, this picture was, of holding a child and, you know, trying to get them to emote and forcibly attach to you. And just these things have been debunked long ago. And in fact, some therapists have gone to jail because they've taught parents to do holding therapy, and kids have died. I mean, it's pretty serious. So it's not just that there's no evidence, but some serious consequences. Things like attachment parenting, that term I think has multiple definitions now. For a while, it was really about, you know, helping kids with obedience, sort of teaching kids to obey, rather than now you hear attachment parenting and it's more like feed kids when they need it, you know, follow the child's cues, that sort of thing. So depending on the context in which you hear it, there have been folks who really advocate kind of a militaristic style of parenting with kids with attachment issues. And again, there's no evidence for their efficacy. So help educate families as they come to you with these questions, if they hear things. Like I said, they've been debunked, and all the professional organizations have opposed them publicly. So what do we do? You're like, that's great, but what do we do? So the American Professional Society on the Abuse of Children came out with a report in 2006 that's been endorsed by a number of organizations, and the reference is there, and also at the end of my slides if you want to look at it. They came out with, you know, what are the best practices? And so they said, starting with assessment, make sure the child is really appropriately assessed by somebody who knows what they're doing. So somebody with expertise in child development that does an appropriate attachment interview. A good attachment interview and assessment is going to take place over several sessions with caregivers, anyone who's involved in the child's life. Looking at behavior across time, across situations, not just with one caregiver, and will be considerate of cultural issues. You know, it was thought for a time if a child didn't make good eye contact, then that meant they couldn't attach or wouldn't attach. That's not necessarily true. And so we want to consider, you know, is that culturally appropriate? Maybe the child's taught not to look an adult in the eye and that sort of thing. So just being very careful about assessment and being careful about hearing sort of word of mouth. So we see this a lot at the COE, that something will get put in a record somewhere and then it just gets carried forward. And so every provider that a child sees from then on out kind of carries that diagnosis with them. And we're looking through the records trying to figure out where this diagnosis came from, and we can't find it. Nobody seems to know. So if you hear that a child has this diagnosis, or any diagnosis really, like find out where that came from and make sure there was an appropriate assessment done. A lot of these kids that do have attachment difficulties are also going to have other things. And so make sure you're assessing for those and that you're providing evidence-based treatment for the diagnoses that the child meets criteria for. Make sure you're ruling out other things. Make sure you're considering family and caregiver factors. And certainly never diagnose a child with an attachment disorder just because they're in foster care. Okay. And this is sort of self-explanatory, but certainly good evidence-based interventions are not going to use any type of coercion or label a kid as pathological or psychopaths or portray kids negatively, right? If we have a child who's engaging in negative behavior, we know that all behavior is done for a reason. It's trying to meet a need. So let's figure out what that need is, right? It's not about a child trying to be manipulative or antisocial, right? They need a more adaptive way to express themselves, and how can we help them get there? Oops. So evidence-based interventions are intended to be short-term. They're typically goal-directed, right? We're trying to improve a specific condition or behavior, and they're targeted at caregivers, okay? Any intervention with a child around attachment issues, by definition, has to include the caregiver. Always, always, always. Good interventions are going to focus on safety. They're going to encourage caregiver patience and sensitivity, consistency, and nurturance, right? And caregiver, again, will always be involved. There was a meta-analysis done in 2003 looking at evidence-based treatments for attachment, and all of those factors were present in the good interventions, and you'll see, I'll give you a list of some as well. But these are kind of the big components, right, in treatment. So if you're working with a child with difficult attachment, obviously you're going to have to involve the caregiver, as I said. And what do you do with the caregiver? I mean, the caregiver can use some time by themselves just for education, educate the caregiver about where this behavior is coming from, educate them about attachment, how that develops, and maybe how this didn't develop in this child. Help them with behavior management, okay, appropriate behavior management strategies to improve behavior, and give them support, right? If you're working with a child that is insecurely attached or is having difficulty with attachment, that's really tough. And many foster parents will say, well, I had my own biological children and I did not have to deal with this. And you say, I know, because they had a healthy attachment with you and this child does not, but we're going to develop one, but it's going to take time. So the caregivers in this situation really do need a lot of support. And then you're going to have them meet together, right? Do activities that are going to help build their attachment together. You can do things in the office, but have them both involved. You're very rarely going to meet with a child by themselves. I would only do that in exceptional cases where maybe you need to establish rapport with the child, help the child feel safe with you or something. But treating attachment is never going to involve you just meeting with the child, right? The caregiver must be involved. So some tips for helping with relationship building, right? Helping the caregivers know how to spend time with the child and how to interact with the child appropriately. So having time in together, scheduling time together. Just PCIT does a really nice job of this. Schedule 5 minutes together a day where it's just special play time. You and the child-directed play, right? Let the child pick something fun, something where you can just be with the child and give them positive feedback, positive regard, that positive attention without chores or instructions or negative feedback. And it's hard with kids that are always getting in trouble and have behavior problems, right? This is hard for parents, and we know that it's hard. That's why we start with just a short amount of time, right? But encouraging them to do positive things together so they can build that relationship. And even instructing parents, sometimes I'll tell them, like, you know, this child didn't get the mirroring and the interaction that you did with your other kids. That thing you do with babies, I'll talk to them about that interaction with babies. I'll say, maybe this child didn't get that, so let's give it to them now. Narrate what they're doing, you know, mirror their feelings, label their feelings for them as they're expressing themselves. Kind of do what you would do with a much younger child. Help them learn to self-regulate. You can help them with that now. Teaching good behavior modification skills, you know, first of all, focusing on the positive, right? Focusing on positive reinforcement. So labeling, praising, giving positive attention, rewards for things that they do. And some parents need help understanding what rewards are. It doesn't have to be money, it doesn't have to be toys, right? Like your attention, your praise. Thank you so much for cleaning up your blocks. You did a great job. I love it when you're a good helper, right? So focusing on positive reinforcement. Setting up rules in advance with the child so the child knows what expectations are. The more clear parents can make those expectations, the better the child will do. So set those up in advance and then follow the rules. You don't have to be the bad guy, right? This is the rule. This is the rule in our house. We don't hit, or we clean up after ourselves, or whatever. Consistency is huge. Don't threaten unless you're going to follow through, right? Be consistent. Keep your routines and rituals the same. Be consistent in how you discipline. Don't just discipline when you're angry. If you mess up, admit your own mistakes and model good coping. Don't yell at the child and then be mad at the child when they yell at their sibling, right? So these are examples of evidence-based treatments. We have several of these in Tennessee. Parent-child interaction therapy for kids 2 to 7. This is really parent coaching, live parent coaching, and it's amazing. It works really well and has saved a number of placements. Once parents learn how to interact appropriately with their child, praising them, doing all the good things, and establishing that relationship before they start disciplining, and then knowing how to discipline effectively. Child-parent psychotherapy, this is for parents and their caregivers where there's been a trauma in the child's history or in the caregiver's history, and this is for infants up through age 5, I believe, and it's really working on the attachment. Again, you're meeting with the caregiver for a while for some assessments, but then you're with the baby or the toddler and the parent together working on that relationship. The ABC intervention is similar, only it's done in the home, and you're really teaching caregivers about attachment behaviors. Circle of security, also one of the first attachment interventions actually, and we saw some of that. The Incredible Years is really about also educating teachers and is used a lot in schools with parents to help stabilize behaviors. And then Parenting the Defiant Child is a Cadston model that's really a behavioral intervention for kids who are disruptive. But you can see all of those interventions have a very heavy focus on the caregiver, right? They're the change agent. These are some examples of other promising practices that have that real focus on attachment and nurturance. So the APSAC report just kind of cautions professionals about, you know, don't follow word of mouth, don't endorse anything that's abusive or that treats the child as pathological, as I mentioned earlier. And then never be wary of books or websites or any place that claims that they have the answer and they can treat reactive attachment disorder and nobody else can, because that's not ethical or true. And what do I tell parents? That that kids with attachment problems can be helped. They can form healthy attachments. We have good interventions for those kids, and so not to despair. Their child is not destined to a life of crime or loneliness, right? That they can form healthy attachments. Okay, that is the end of my slides, and I know I'm a little bit over. So if people have to go, I totally understand. If you have to jump off, I'm willing to stay for a few minutes if people have questions.
Nothing came through as far as that we haven't talked about, but just a lot of people wanting the slides. And if you want to get in touch with our administrative specialist by just replying to the email that sent you the invitation, that's the fastest way to get in touch with her. I'm sure we can accommodate some form there. Do you recommend for children over 7? What do you recommend for children or over 7 or adolescents? Is a question came in.
Yeah, great question. So some of those same things, some of the same evidence-based. Let me pull up my slide here for building that healthy attachment. So the same things: safety, patience, sensitivity, consistency. Doing relationship building with the adolescent. Have the adolescent pick an activity. What do they want to do? Let's spend some time together doing something you want to do and doing something positive where I'm not criticizing you or questioning you, right? And even doing some of the narration and mirroring of the feelings. Like I worked with some kids that were in middle school that were severely neglected and they were malnourished and probably met the criteria for reactive attachment, and they like didn't know what they were feeling. Like they didn't even know, they couldn't tell you. And I think they just generally didn't understand how feelings worked. And so I worked with mom on, you know, when you're doing something, look at her facial expression, point it out to her, label it. Oh, it looks like you're really enjoying this one. Or, oh, it looks like you're really angry when we do this. Tell me about this. And help them develop a language and help them identify their feelings. And same with behavior modification. I mean, same kind of thing. You want to have consistency. You want to have predictability. You're going to do the same thing with a teenager or an older child. You know, your consequences might be different. You're not going to do a timeout with an adolescent, but you might have a calm down space with them. You might have, you know, certain consequences that they have to do, extra chores or something to earn privileges, you know, that sort of thing. So the same basic concepts apply even to older kids. It just might look a little bit different in terms of what your rewards are, that sort of thing. Really good question.
All right, I said thank you. If there's no other questions, doesn't look like it. We'll give this a wrap. I want to thank everybody for their participation and thank Dr. Dean very much for presenting with us today. In short order, this will be put on YouTube as well for those who need to review it or came in late and didn't get to see everything. So thank you all, and somebody just raised their hand. Hold on. Well, I guess they left. Maybe they're trying to leave. Okay. So thank you all, and we look forward to seeing you at our next Learning Cafe in July there, where Dr. Corwin, I think, will be presenting for us. Take care, everybody.
Thanks, everyone.